Hello and welcome at EAO's Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I have the honor to be the host of the EAO channel. And in tonight's live video session, we're going to try to answer as many of your questions on placing implants in patients with systemic diseases. And I'm very proud that tonight I'm joined by Victor Palarie. He is a maxillofacial surgeon from Moldova. And Victor, good evening.
Good evening, Gerrit. Good to see you today.
Yes, welcome. When we chatted earlier, you explained to me you work in a multidisciplinary medical center where you see all very diverse type of patients. And that's why you also know a lot about all these specific patients type with underlying systemic diseases. And tonight, we're going to try to understand why that is important for the implant dentistry field. I'm very happy that you're with us, Victor.
Yes, it is correct. We'll try to talk about a spectrum of diseases. To make an introduction, there are like more than 6,000 diseases. So we'll try to summarize most important of them.
Yeah, we'll try to summarize on those with the most incidents. And important, when we talked last week, we also mentioned that probably we'll talk a bit about the impact of different drugs on the protocols and on the treatment of implant dentistry. And we have a request to all our viewers, please don't use any specific names of drugs because they can be different around the globe. But if you are referring your questions about certain drugs, talk about the type of drugs. So we can also understand and our global audience can understand what you are talking about. And you can participate. If this is your first ever Just Ask, we're going to, in a minute, introduce the topic briefly, and then we're going to open the floor up to you. You can send in your questions via the live chat window here on the right side of your screen. And I already asked a couple of minutes ago, if you're watching this now, please let us know who you are and where in the world you are joining us from. And we saw already quite early that Dr. Mitchell Pierce, is joining us from New Orleans, Louisiana. So I would say good afternoon, I guess, to Dr. Pierce. We have Fabio Vidal with us from Rio de Janeiro in Brazil. If you're watching this right now, please use this chat function to let us know who you are and where you're joining us from. And I'll make a shout out to some more of our viewers in a minute. But first, Victor, if you can start with a small introduction of why it is relevant tonight to talk about patients with systemic diseases. I believe you've prepared some slides for us.
Yes, correct. Well, talking about the systemic diseases, first of all, we need to mention that we have the oral manifestation of systemic diseases. And from the ancient years, from Hippocrates and from Avicenna, we know that oral cavity is a mirror of the rest of the body. So a dentist, usually, and a lot of times, the dentist could be the first doctor who recognize systemic, chronic diseases, even looking into the mouth. So we have specific signs in the mouth, which can lead us to a hypothesis that this patient also has a chronic diseases. For example, severe periodontal inflammation of bleeding associated with excessive thirst, polydipsia. It can lead us to conclusion that the patient has also diabetes, maybe he has HIV, maybe he has a leukemia. The mucogingivitis, we can think if we have a patient with chronic mucogingivitis that this patient has also Crohn's disease. This is inflammation of the intestine or the whole gastrointestinal tract, which start from the mouth to the anus. Oral, we can have the oral ulcerations, plaques, erythema. So this can be a sign for the lupus erythematosus. For example, different pigmentation in the mouth. You can think about Addison diseases. And also, if we see attached the white patch on the oral mucosa, it's the first sign of the leukoplakia, which is a precancer, and it's seen mostly in the people who are a smoker or chewing tobacco. So, and very often these signs are first signs of these severe diseases. And if we see these patients, it's really good to send them for the medical doctor for consultation. So Actually, another important topic is the pathways of the oral infection in patients of systemic diseases. They have couple mechanisms. One, this infection from the oral cavity can be spread to the other organs. For example, if we have a metastatic infection which is sent to the heart via bacteremia, so we can have a subacute endocarditis, we can abscesses, and also we can have the prosthetic joint infections in patients who had the replacement of the knee or of the femur. We can have different metastatic injuries, and which the infection can go to the brain, and we can have the cerebral infarction. We can have the stroke. We can have the problems of pregnant women. So we can have the toxic shock syndrome. And of course, we can have inflammation of the other organs which are already involved in these systemic conditions.
Yeah. So first key takeaway of tonight, the oral cavity as a mirror of the rest of the body. That puts quite a large responsibility on us as dentists, right? Because yes, we see these patients on a regular basis. They come walk in, and we might be the first to see a hint of what might be going on in the body without the patient even knowing it yet. And yes, I think that's why it's very important that we draw attention to this tonight. In the meantime, Victor, our colleagues from around the world are checking in. I want to read out a few. We have Zekiang Chu from Germany, Ioana Susiu from Bucharest in Romania, Christopher Apokis from Sweden, very loyal participant. Good night, Christopher. We have Jaakko Pakarinen from Finland, Ricardo Curcio from Brazil, Martin Janega from the Czech Republic, Michael Poirier from Austria, and many more. We see Dan Kreku also from Moldova joining us, Brenda Mertens from France. So good evening all and welcome. We've just started. And Victor, you mentioned there's over 60,000 diseases that we could zoom into. Can you share with us what are like the most common that we could encounter in our practices?
Well, in the University of New York, they did summarize which diseases we can see more in our dental practices, or which what type of patients we'll see, and especially they can come also for the implant treatment. And the first type, there are patients of arthritis. Then there are patients of hypertension, patients of heart diseases, chronic sinusitis. This means that it's very important it's very important topic when we speak about sinus lift. The chronic sinusitis can have different etiology, for example, from dental origin, allergic origin, or rhinogenic origin. So when we start to do a sinus lift procedure, is very important to diagnose this sinusitis. And if you have it, it's very good to send the patient for the ENT doctor. Another severe condition is diabetes. Then we have allergic rhinitis. We see patients mostly autumn and spring because of the flowers and of the climatic changes.
Yeah, the layman term of that is hay fever, right?
Yes,
I
yes,
even
correct.
suffer from it a little bit. So this is very common, I assume.
Yes, it's very common. So we can have the patients of varicositis. We can have patients of hernia and hemorrhoids. So these three diseases are really important to know, because suddenly the patient can stand up from your chair because he have a pain in the back. And we had this patient, normally they come to the office with a pillow because they want to put a pillow under the back. So, and then is the chronic bronchitis. It is infection of chronic infection of the lungs. And it's very common today when we have this COVID epidemic today.
A lot of patients with lung problems. And when you go through the list, we already hear that some things might not seem that obvious, how they would influence our protocols or treatment. But then, for example, with the example of the hernia, it has nothing to do with the oral cavity, but with the fact that a patient cannot lie down for a very long
imagine
time.
when you do a GBR technique and the patient won't say, I suddenly have the pain in the back. So you also I forgot to mention that this is most of these diseases are seen in elderly patients, and today we have aging countries. Mm-hmm. And we see it today, and these patients are in risk list today of COVID situation. So it's really important. You need to keep in mind, because if the patient is old, elderly patient with the chronic diseases, so he is in a risk part to get a virus infection even today.
So we need to carefully examine our patients before we allow them, or before we decide on the treatment or the protocol. What are some of the treatment considerations when we are dealing with patients with systemic diseases?
Well, I think to talk about the consideration, I think we could perhaps go to our cases, because we have some submitted cases from our guests. And if you go to these cases, I will try to explain for each case in part how should we deal.
Yes, let's do that. For those of you who watch this Just Ask Live for the first time, you can send in any questions while we are live. If you hear Victor explain anything, it's not exactly clear to you, ask a clarifying question. Or if you came to the session with already a pre-prepared question, you can submit it as well. But the opportunity is also there to send in your cases. And tonight, two people have done that before. We have Maria Duka from Finland, who has a case with a patient with an odontoma, a tumor in the maxilla. We'll treat that one next. And we have Dan Greco, who we already saw is joining us tonight, who is a general practitioner from Moldova, we just learned. And he has also sent this case. Shall we start with that case, Victor?
Yes, but before, when we'll talk about the cases, we'll talk about the medication with the patient they get. And we know in each disease there are specific medications, and if the patient has 2 or 3 more diseases, he'll get more drugs. So from beginning of treatment, it's very important to know from the patient what drugs does he get from his medical doctor, and to know if these drugs have an impact to the treatment and to the osseointegration phenomenon. So let's go to the first case. This is a patient, a male, 65 years old, of diabetes type 2. So from medical history, 7 years ago, he suffered a heart infarct with a stent implantation in the first 7 hours after heart infarct. And he have a HbC analysis between 7 and 10. So he is on insulin once per day. Also, he has Plavix once per day, and then bisoprolol for the hypertension. And the question is if you could advise with a protocol for treatment in this case. Well, I need to go a little bit to the medical field now.
Where do we start?
Well, we start with diabetes. We need to know that we have 2 types of diabetes. Is type 1 is insulin dependent, and type 2 is non-insulin dependent. Type 1 is mostly seen in young population. It's autoimmune disease, which this disease destroy pancreas cells and lead to the insufficient production of insulin. So these patients, they are most vulnerable patients. Till today, the mechanism of action of diabetes to the bone resorption is not really well studied. We have just preclinical studies, especially on the rats. These patients are most complicated. Type 2 is they have a resistance to insulin in combination of production additional compulsory insulin. So this diabetes is seen more after 45 years old. It's related mostly with the nutrition factor. So this is the easiest part of diabetes. Also, diabetes, if it's not controlled, it has 2 types of severe complications. It has macrovascular complications and microvascular complications. So we have complications of the eye, retinopathy, which is very important to know for us to know it, nephropathy, neuropathy, we have macrovascular disturbances, we have problems with wound healing, and the 6th official complication for diabetes we have in oral cavity. So we have a severe periodontitis associated with candidosis and with a lot of caries. So if we carefully see that this X-ray, I see, first of all, we have problems with periodontitis in the lower jaw. And I think the first point is now to look at for the treatment for the periodontitis. because we have periodontitis compromised teeth. And maybe perhaps we should do some teeth extraction. But look, going back to the diabetes, today the diabetes is a pandemic of this century. So expectation for this year that we will have 20% of the population of the globe will have diabetes. And this disease is not for the poor people or for the rich, it's for everybody. It affects a lot. We have different types to control the level of glucose in the blood. And the most indicated is to know glycated hemoglobin, which is a mean of the glucose in the blood for 3 months. So the ideal number for the hemoglobin, glucose hemoglobin is up to 6. Then from 7 to 8 is optimal or good. And then is more than 9, we have problems. So also it's very important to know that patients with diabetes, they have association of osteopenia or osteoporosis. So we need to send the patient for the control for osteoporosis. And if the patient doesn't have any other complications. The most severe, we have the macrovascular complications. This is necrosis of the fingers or the foot. Of course, if you have such patient, we cannot treat him because it's.
So Victor, are you saying like when I check in a new patient, I obviously have this whole form and I have them fill out. Do you yes. suffer from any systemic Correct. Diseases? They check, yes, I'm diabetes type 2. And then the next thing is to start to look or ask for these kind of complications. Yes. And you already say when you have necrosis, it's a contraindication. We're not going to do it.
Then we ask the patient if they have the complications of the eye. It's retinopathy, so it's meaning it's a microvascular complication, which meaning they have a lot of new vessels on the retina of the eye. So, and these are immature vessels. So, and that's why the patient can lose the eye. So it's really related to the oral cavity, because if you have this a lot of new vessels, so we'll have the same in the oral mucosa. So these new vessels will lead us to have, we could have some complications like improper wound healing, infection, and as well as problems of the bone maturation after implant placement. So the ideal number for glycoside hemoglobin level is around 7 for diabetic patients. So if, as we see from this case, he's from 7 to 8, then perhaps he needs adjustment of his treatment. Maybe he needs to increase the insulin dosage, not once per day, but twice per day. So that's why we need to refer this patient back to his endocrinologist to make the control of the adjustment in his treatment.
Yeah, that's another very important takeaway. That as an implant dentist, you team up with the other physicians around this patient.
Correct.
Yeah.
And then for this patient, it's very important to have antibiotic prophylaxis. It is recommended. So this should be discussed also with his endocrinologist, because they know better which antibiotics is more suitable for this patient. And of course, he should have shorter recall intervals to detect any possible post-operative complications like wound infection. So the next part, he has Plavix. So he is on anticoagulants. He has heart infarct. It's very good that he was stented. It's stented as well in 7 hours. They put they made a small surgery on the heart, and they opened this dead zone of the heart. And then to avoid any problems of formation of the thrombosis, these patients on the lifetime on anticoagulants. So the Plavix, we have actually we have 3 types of the oral anticoagulants. First is Plavix, it's the same like aspirin, but it's better than for patient. We have the risk is minor for the hemorrhage because we have prolonged bleeding time. So it's recommended to avoid flap procedures and to have large zone for the implant placement or for teeth extraction. If we have some hemorrhage after that, we can use local sponges or some local agents to stop the bleeding. The second drug is most common use is warfarin or Coumadin. This is okay. It's a vitamin K antagonist, and these patients, they are one of the most complicated patients because these patients are of chronic atrial rhythm problems. They are patients after joint prosthesis, and they are of deep vein thrombosis. So for such patients, we need to have a special analysis called international normalized ratio, NR. Normally for me and for you is from 0.8 till 1.2 because we are not on anticoagulants. NR level is increased for the patient of warfarin is between 2 or 3 and can be even more if the patient has problems with the heart valves. So in such patients, there was a consensus conference of the EO, and they formulated that for the minor oral surgery procedures, minor implant procedures, we don't need to discontinue this anticoagulant therapy, and we need to avoid major bone augmentation procedures, because the risk to suspend this treatment and to make a diet for this anticoagulant therapy is there is a high risk for the life of the patient, because we can have a lot of complications like stroke or even the death of patient. The third one is the group of the novel oral anticoagulants. So they appeared a couple of years ago. There are not studies regarding these anticoagulants and oral surgery and even implant procedures. There are just few in the literature. There are a few cases. So the good thing is that they don't have changes of this NR level, but we have changes in the time of the bleeding. The risky factor for this drug is because still today there is not specific antidote. So if the patient have bleeding, so we cannot stop. So there are protocols to change the some anticoagulant drugs, but this should be done of cardiologist first of all. But it's very important to keep in mind, if you have a patient of heart valve prosthesis, of high hypertension, and diabetes together, all in that, so this is really, it's a contraindication for implant placement or oral surgery procedures in the regular dental office. So you need to refer these patients to the hospital. There they should take care of them. We have intravenous anticoagulant medications. This one, we don't see this in the dental practices because they're in the hospital. And we have subcutaneous medications. It's like a fluoxetine. So if we have a pregnant woman, we should ask her, okay, we don't place for hair implants, but maybe she's coming for teeth extraction. We should ask her if she doesn't use any subcutaneous anticoagulants. They are prescribed more in women of negative rhesus factor, because the second pregnancy they have the risk of spontaneous abortion. So these anticoagulants are prescribed to avoid this spontaneous abortion in a pregnant woman. Also, in pregnant women, it's very important to ask if they don't have diabetes, because there is a subtype of diabetes called diabetes for pregnant women. Because of the changes in the organ endocrine system, they have diabetes. It's a transitorium form, but it's a diabetes. So we need to be for if you have pregnant women, it's two very important questions: diabetes and pregnancy, and if they have anticoagulants during pregnancy. So this is what we need to know about the anticoagulants.
Mm-hmm. So we're really unraveling this patient. First, we talked about diabetes and how it could be a risk factor or a contraindication. Next step, because it's also a hypertension patient, we need to consider the anticoagulant medication. Very well explained. Our viewers are complimenting you. What is the next step?
Well, from these drugs, what he has now, if this patient will have controlled diabetes, Plavix is not a contraindication for the implants. I don't see any contraindications. What I will advise our colleague is to avoid the flap procedures and to use the flapless procedure. And this patient is ideal for the all-on-4 technique. We will avoid sinus lift technique, and we will avoid big cuts. So I don't see if he will use the guided surgery. And for implants, I think there will be not a problem for this patient. And for example, this is a case, how we'll treat it. Well, this is, we started a study of all-on-4. Half of implants we placed to achieve cortical fixation, and another plant without cortical fixation. So, and this is another systemic disease which we see in our office, and I think you can see the red rash on the face, yes?
Yeah.
What do you think, what is that?
Don't do this, Victor. I'm not a clinician. No,
okay.
I don't dare to answer that. Maybe our viewers will.
Okay,
yeah.
have you watched Dr. House movie?
Maybe,
so
but the red rash is an indication, yes.
It's a lupus.
Okay.
So it's a rare autoimmune disease which affects also the bone. So for such patients, we go, we don't use a bone augmentation. We just place implants where it's possible because it's really, they're risky patients. So,
and I have to say, Fabio Vidal from Brazil, thank you. He indeed also answered, is it a lupus? And yes, indeed. So our viewers saved the day.
So, good. We can go to the second case or not?
Yeah, wait. Before you move on, I want to summarize this case because we have Dan Greco also with us, and he just submitted another follow-up question, but I think you just answered it, but let's go slow on that. Is it better for such a patient to do a guided implant surgery rather than a classical approach to reduce the trauma? And I think you just very quickly said yes to that. So in general, you say, and is that driven by the diabetes or by the fact that there's anticoagulant drugs? What is the key indicator that you go for as simple procedure as possible?
Both, but more is anticoagulation therapy.
Exactly. And well, Dan is actively with us. He now says, so what is your prognosis of success of implant placement to such a patient? Because
well,
it is clear there's no contra-education. You already mentioned there's a lot of risks. There's a lot of extra things you should do. You should definitely contact the other doctors involved with this patient. Can you say anything about?
I think the survival rate is, we cannot talk about success, but survival rate is quite good. It strongly depends on the patient. If you achieve a good osseointegration, it strongly depends on the patient about his hygiene and the medication, especially diabetes, to diabetes to be controlled. If the diabetes will not be controlled, then we'll have complications like infection and candidosis, which then will have a problem. So, but if the patient is controlled, non-smoker, then it's quite good prognosis.
Yeah. Yeah. And are you saying, so in this patient, we're dealing with hypertension, dealing with diabetes, the main risks are basically during the surgery and the operation and not so much later in the osseointegration? Or is there a play of both?
Well, when we talk even about systemic diseases, we can have complications at any step of our treatment, because we need to understand the chronic diseases, they change the full organism, the full body, and we can expect it doesn't matter when. So we can have during surgery, immediately post-operative because infection, or if the patient is not controlled, so we can have the problems of implants post-integration period because we can have a lot of bone loss due to non-controlled associated with infection. So this is the key.
Exactly. Last very specific question from Dan Greco. Again, we're live and Dan is with us live, and he says, so do we need to keep the glucose levels under 8?
Yes.
I don't know if you're the right doctor to answer that.
Between 7 and 8.
Exactly. Yeah, and that is then if the patient succeeds to do that for long term, they should be okay.
Yes.
All right. Wow, Victor, I'm impressed, and our viewers also. Is a very clear explanation and a very step-by-step. I'm learning a lot here. I think our viewers are well. We saw a question coming in from Jaakko Pakarinen. He also says, very good explanation and examples. And he would like to ask the relation between implants and chemotherapy of cancer patients. And I think that's a great segue to bolt on to our next case, perhaps, of
Yes.
Maria Duca?
Correct. We can go.
Yeah, why don't you introduce the second case?
Well, we have a case, interesting case. Male patient, he's for implant surgery. During X-ray, they noted a mass like a tumor. Yes, it's like an odontoma. He has type 2 compensated diabetes. So this is not when we talk about compensated diabetes, it's between 7 and 8. So we don't talk about diabetes now. So
that is what that term compensated means.
Compensated,
under
yes.
control and the patient.
Compensated. Yeah. So what should we do and implant rehabilitation? Well, for me, from this X-ray, it seems like it's a complex odontoma. Why complex? Because we have all types of the teeth structures in this tumor. We have also.
Can you help us view this X-ray image, Victor? Where do we need to look and what do we see?
Okay, I don't think.
Yeah, your mouse is on the screen. Oh.
So it's a big mass. You can see a lot of teeth inside. So this is a tumor. The origin, it's controversial origin of this tumor. Here we see all parts of the teeth. We have the dentin, we have the cement, we have the enamel. Also we see the soft tissue. It's a benign tumor. We need to remove it. Of course, we need to send it for histology. But what we need, and then we can make bone augmentation, place implants. I'll not stop this topic because it was discussed in the previous Just Ask sessions. What is important to know about odontoma and actually about all impacted teeth? So when we have on the X-ray impacted teeth, we should to know in 30% of the cases, these impacted teeth or these tumors are associated with Gardner syndrome. Gardner syndrome is familial adenomatous polyposis. What does it mean? The patient has a lot of polyps in the intestines. Well, and it's associated with another sign on the retina. So it's called congenital hypertrophy of retinal pigment epithelium, like beer tracks. And I would like to show you one of our case, a patient who has an impacted tooth. We asked about if the patient has any relatives regarding of the cancer of the intestine. Patient said that his uncle died from the adenocarcinoma of the intestine. So this is the first sign. We sent him for the ophthalmology, and you see on the retina beer tracks. You see it like with the beer. So this is another sign. And then
is this an extra procedure you do? Are you requesting a scan of the retina?
Yes. If you have a family impacted teeth, if you have a family patient had cancer history in some of his relatives, then we send it. Then we send, if these two factors are positive, then we send him for the endoscopy for the general surgeon, and they found for him a lot of polyps. So this is a precancer, because if it starts to be a cancer, it's adenocarcinoma, 100% it's metastatic, and the life is around 2 years. So patient had removed these polyps, and then we can say that we were first who diagnosed this severe cancer. So that's why sometimes it's really important to clarify if these syndromes, because they are related to impacted teeth. There are not too many. For example, statistically, there are 3 patients per 1,000 population, but still there are.
You don't want to miss it, yeah. Yes, and this comes back to when we started this Just Ask, where you say the oral cavity is the mirror of the rest of the body. Yeah?
Correct.
Yeah.
So
what next?
Another case related, but for me was always the question if implant can be a start of a tumor.
Okay.
So, and I had a patient, I was lucky. And this case we published in Inspired, which is a journal of the EAO. And you can look on the EO.org, and you can look at our publications there, Inspired, and as well as other journals. So the patient was referred to us with the maxillary sinusitis, infection of the sinus in the left part, and ptosis. Ptosis meaning dropping of the upper eyelid, diplopia, double vision of the left eye. So she has 2 implants. Here we see some bone resorption, some infection. And the first we thought that it's okay, it's a direct complication of the infection from the implant. We removed the implant, the sinusitis disappeared, but the diplopia and ptosis didn't disappear. So we understand that this is not related to the infection. We sent the patient for neurological examination. He did a CT, and they found a disease, very rare disease called Myasthenia gravis. So it's a tumor of the thymus. Thymus is a gland, an endocrine gland, which is situated behind the heart, and which normally disappears. It's present only in children, and then at the age of 15, it completely disappears. But in some patients, it's still present, and it's transformed to a tumor. It's a malignant tumor. So, and it will start manifestation when it has an impact, a strong impact. So this is stress, or it's an infection. So this infection from the implant started wake up this tumor from the sleeping. So we, of course, the patient we sent to exclude from other chronic diseases. He was clean after other possible autoimmune disease. And we sent him for surgery, for a thoracic surgery. Here you can see the heart. And here you see endoscopic removal of the tumor. It's between lungs and near the heart. It's really a very scary video, but somehow we saved the life of the patient, and because we sent to the correct doctor. This patient is also on the lifetime on the corticosteroids because in special medications, but at the end we understood that it was the first case for me when we saw the direct relation between complication after implant placement and the tumor, a rare tumor.
And is this, where do we need to understand this case? Is this a very rare incident, or can you say anything about the incidence?
It's very rare.
Relations? Yeah.
It's very rare. Normally, it's very rare. Normally, we can see it in women, not in men. He was a man. But normally, it appears in the early, the patient was 60 years old. Normally, we can see it around 20, 30 because when the patient woman got pregnant, or there is a high risk. But this was a sleeping tumor, 60 years sleeping tumor, and with manifestation just after infection.
Wow. Thank you for explaining this case. If you are just joining us, welcome to this Just Ask, where we are live with Dr. Victor Palarie from Moldova, talking about implants in patients with systemic diseases. We've already learned that the oral cavity can be a mirror of the rest of the body, that we should examine our patients very, very well, and that if we run into a case with systemic diseases, whether it's diabetes, hypertension, or any other of the many common systemic diseases nowadays, it's always wise to connect with the other medical professionals around this patient and make sure you align your treatment plans and protocols. We have some questions coming in for you, Victor. One is back to the topic of diabetes. Fabio Vidal is asking regarding the drugs used for diabetes. And here we have 2 drug names, such as liraglutide and rosiglitazone. We already said, Fabio, please refer to the type of drugs because they might be called different around the world. We have some anecdotal reports of implant failure related to possible effects of such drugs on the bone metabolism. Do you have any data or experience with patients using such medication? Let's broaden that up. Is there a relation between anti-diabetes drugs and these kind of effects?
Well, anti-diabetes not, because the diabetes drugs usually they help us. Mm-hmm. We have experience of bisphosphonate, which are osteoporosis. And if the patient with diabetes and osteoporosis, then perhaps yes.
So let's zoom into this one. Let me quickly close your slide share for a second here. So we can see you again. So can you share a little bit about that? Because patients, especially elderly patients with osteoporosis, what is the effect on the osseointegration there?
Well, the osteoporosis, when we talk about osteoporosis, we need to understand that there are common osteoporosis, which is seen mostly in postmenopausal women, or it's associated with other systemic disease or a response from other systemic disease. The osteoporosis is the problem is what happened. It's related to the bone metabolism, and we have immature bone formation. So normally, when we have osteoporosis, we need more time in the healing of the implants. But the most important thing we need to know that this patient, if they have a severe osteoporosis, they are on bisphosphonates. So these bisphosphonates can cause for us really severe problems. So it depends if the patient is on oral or intravenous bisphosphonates, so we can conclude what we need to do with this patient.
Okay, and what is the effect of the biphosphonate drug?
I think we can go to the biphosphonates because we have some slides here.
Prepared? Yeah.
Yes, I think we have some slides here.
You need to reshare your screen so we can see it.
Yes, I do. So now, do you see it?
Yes.
It's okay. Well, we have primary osteoporosis, as I said, it's mostly from postmenopausal women. It's age-related osteoporosis, and then we can have secondary osteoporosis. And you see there is a list of 25 degrees. Perhaps there are more, but for my knowledge, there are 25 degrees which can cause osteoporosis. And of course, the treatment from these diseases and osteoporosis is a really combination which can have an effect to the bone metabolism, and for the we can have problems of osseointegration. It's possible to do bone augmentation in patients of osteoporosis if they are compensated and if they are not on the biphosphonates. So biphosphonates can induce a disease called the biphosphonate-related osteonecrosis. My former chief from Germany and my scientific advisor, Bilal Al-Nawaz, he has a center in Mainz when they studied these biphosphonates, and they have some conclusions. As well, the European Association of Osteointegration has had a consensus conference 2 years ago regarding how can we deal with the biphosphonates. So this osteonecrosis is exposed bone in the jaws, in the mouth, and it can be these biphosphonates can be administered also in patients with metastasis in the bones, in melanoma. So these are risky patients for us, and mostly we see it in biphosphonates, intravenous biphosphonates. So this is a case. So for example, in the first picture, we see a dead bone in the mouth. And what is outside, we see at the abscess, we see a lot of the pus. And on X-ray, we see the dead bone. And we have some periimplantitis of the implants. So this patient, it's really difficult to treat these patients because we need to have a really to cut the mandible and a long period of rehabilitation. So my recommendations, and as well as from European Association of Osteointegration, is if you have intravenous patients, to avoid any oral surgery procedures, also implant surgeries. There are not sufficient data regarding oral bisphosphonates, and it seems that it's okay if you have the minor oral surgery on implant placement procedures. So, and there is no evidence if the patient has a drug holiday.
Okay, because this is a related question from Chloe Karen Aboud, who just came in. What about for biphosphonates administered once per year for osteoporosis? Is that a contraindication for implant placement as well?
Well, normally biphosphonates are not indicated once per year, they're a little more. We need to if we'll go for the next cases, it's proved that at minimum we need
Chloe is adding that it's intravenous.
Intravenous. Well, yes, it's a contraindication.
In that case, yes, very clear answer. Yes, thank you. We have some more questions coming in. One from Victor Gerrit. If we are done with the topic of osteoporosis for now, we can come back.
Yes, we can go a little bit further.
Yeah. So let me take away the slide for you so we can both see us. Question from Victor Gerrit. He is asking, so what are the risks for implant treatment in patients with chronic illness? And there it is, in the COVID pandemia. So does this add an extra factor of complications? And if so, how? And I know it's a very broad question, but what can you say about that?
Okay, we had a few weeks ago a very nice Just Ask session regarding COVID.
Yes.
With colleagues from China, Hong Kong, and Austria. But anyway, for me, first of all, advice is to look for official documents of the national authorities, because each country has a specific documents and how to treat different types of patients. But for me, before COVID and in COVID period, and according to recommendations of our medical colleagues from general medicine, we treat these patients in the first half of the day, preferably in the morning, because they should, without any stress, they should have slept well, a good breakfast, because the problem is in such patients, especially diabetes, we can have a severe complications and emergencies is hypoglycemia. So when the level of the glucose is down, or hyperglycemia, level of glucose is too high, because it didn't take, it's too long time between their medications. Or for example, in other endocrinologic disease like Alzheimer's disease, we can have the increase of the cortisol in the blood, and then they can also go to the severe risk for the life. Normally, this patient, they have a card where they write. Normally, they feel if they have the diabetic patients. Normally, they have a pen of insulin, or they have some sugar or some chocolate when they eat it, and then it's okay. But for me, recommendation is the first part of the day. The procedure should be around 30-40 minutes, maximum 1 hour. A lot of rest for the patients, and that's it.
And you're saying, Victor, this is general advice regardless of COVID, right? I think, I think in general, the patients with systemic diseases are under increased risk of this COVID pandemic. And like you said, we had a Just Ask about COVID-19, where we talked a lot about what measures you need to take in the clinic in order to be safe. And that's why you're referring to that. With patients with systemic diseases, I guess it's the simple answer is you need to be even more cautious, right? And yes, perhaps delay if you can. Another question from Ala Zahalka is the name. And one of the favorite topics here in the Just Ask questions about materials. Well, what is the material of choice for the abutment in patients with chronic diseases? Is there any relation between these diseases and material choices? Anything you know of?
Only relation could be if the patient is allergic patient and he has any specific allergies for specific materials. We have for abutment titanium, gold, zirconia, plastics, a lot. So it strongly depends. But I think the relation, if the patient is allergic patient, we need to talk to see if he's allergic. Titanium is very rare, seen as allergy. It's seen mostly about in our orthopedic colleagues, but for me, what is cost-effective abutment, then you'll use it.
Exactly. So there's no direct relation other than perhaps an allergic reaction to the material. No. A question that came a bit earlier already from someone named Alpha Gate, might be the brand name, but we mentioned earlier when we talked about anticoagulant drugs and the risks and staying away from flap surgery. What are the risks for sinus lifts in patients under Coumadin, is the question.
It's a high risk because, as we know, in the sinus lift, you can have a hemorrhage because of the vessel which is going here and the bone. And the risk is really high. And if you have a patient with Coumadin, of course, and also recommendations from a lot of societies is to avoid any big surgeries and bone augmentation procedures.
All right, very short and simple answer. Thank you, Victor. If you are just joining us, we are doing an EAO Just Ask Live. This is your monthly appointment with a leading expert in implant dentistry, and we're talking to Victor Palarie about patients with systemic diseases and the effects or the impact that has on our implant dentistry practices. Another question came in from, well, and I'm saying that if you're just joining us, please use this box on the right of the screen to send in your questions via the live chat, and I'll read them out to Victor. Meshari Al-Damk just did that. And the question is it conditioned, this is back to the topic of biphosphonates, is it conditioned to have oral bony exposure to definitely prove the side effect of the biphosphonate?
Well, we don't see it in all patients with biphosphonates. First cases, we know about this from 2005 from Mark's publications, but not all patients, they have some bone explosion. We see this bone explosion mostly when they had before initiation of the biphosphonates infection diseases in the mouth, like periodontitis, caries, or some periimplantitis. So that's why I advise for endocrinologists who prescribe biphosphonates, and they know this very good, before initiation treatment for biphosphonate, they send this patient to dentist for sanation, to extract the teeth or to treat any infection problems. But I think we can go for other diseases where we see the exposure of related to biphosphonates also for the next case. What do you think, Gerrit?
Yeah, yes, go ahead, Victor. Yes, what case do you have in mind?
About methamphetamine.
Exactly, and the segue in is that often we think about older patients, right? Because we're looking at osteoporosis, which often occurs in elderly patients. But you mentioned earlier when we talked that there is a patient group where you might not expect similar effects.
Well, we have a special patients, young patients, normally from the rich families. They come to us with parents with mobility of the teeth, bone exposed in the mouth, and asking, doctor, please do something because suddenly it happened with my son or with my daughter. We want to have implants. We have to have nice crowns. And we see that, for example, this X-ray, we can see the bone lesion. Mm-hmm. And these cases are from drugs called methamphetamine. It's perventin. It was discovered in 1930 in Germany, and it is composed by red phosphor, epinephrine, and iodine. So it was used a lot in German army, and it was used as a chocolate. It's called Fliegerschokolade or Panzerschokolade. It was used for the pilots and for the soldiers in the tanks. And it was used before invasion of Germany to France. And then Germany produced for this invasion 35 million doses for these drugs. So in high dosage, it's very terrible drug, and because it contains red phosphor, the mechanism of the action is similar like biphosphonates. If you want to read about this drug, it's written in a thriller 61 Hours by Lee Child, when it's described very well in UK, the effect of this drug. And the cost of this drug is much smaller than heroin. Also, these patients, and you need to ask this patient if he's on drugs. Normally, this patient, they come from heroin to this drug because it's much cheaper. But this patient also, usually they have hepatitis C and HIV. So what we see outside, it's abscess. This is we have a colleague in our country, Dr. Radzikevich. He is a specialist in such cases, and he was the first who described these cases. And the idea is you need to resect this part of the mandible, and if the patient will not stop this drug, it will continue with destruction of the whole body, and the patient will die. So it's very important, if you see these young people with such things, to ask if he's not on on perventin.
And again, you're sharing this story about the rich parents coming to your practice because you might, again, as the dentist, be the first to discover this, right? Because the parents might not be aware. It's a secret from the youngster, and
yes,
you come across this, and this is the explanation.
So, for example, you can see here our colleagues how they remove this dead bone, and of course, the life of these patients is it's very difficult to restore such patients. So the unique thing is that they need to stop it. And if going back to bisphosphonates, our colleagues proved that you need to wait at least half a year then to start bone augmentation implant placement in such patients. So making a parallel, we need to wait minimum half year, but the best is 1 year after stopping of administration of these biphosphonates or these drugs.
Because is it similar with the methamphetamine? And because Fotios Papas is just submitting that question as well. How long would you advise to wait before implant placement after stopping oral for biphosphonates?
Well, biphosphonates, they are not stopped like we want. They should be stopped by by the medical, from endocrinology. So biphosphonates are administered because if the patient has a metastasis or have a severe osteoporosis. So I think they will never stop biphosphonates. So for such patients, you cannot do anything.
So you say it's the other way around. We could desire that as implant dentists, but it's not going to happen.
You can decide only in these young patients which are on drugs. Okay, they decide or they stop, and then we continue or not, they will die.
Exactly.
That's all.
Very clear. Victor, there's another type of patients that we might come across in our practices that we haven't discussed, and we got a previously submitted question from someone who used the submit your case opportunity as well, and that is about patients who are transplant recipients, because obviously patients who have received a transplant are on immunosuppressive drugs, and what is the effect for that on our implant dentistry practice?
Well, there are transplant, for my knowledge, I found only 2 meta-analyses, both are by Mariano Sanz group from Spain, one in the renal and one in the liver transplant patients. So they did. I think
you have that slide as well with us, right?
I have it.
Number 18, I think. There you go. There it was, one down.
Okay, it's here, yes. So when we compare this, it's a mean follow-up of 8 years. So when we compare these numbers, we have the survival rate for renal transplant 98%, and for the liver 100%, the survival rate for implant, which is fantastic.
This is the survival rate of the implant, right? Because I happen to have worked a lot in the transplant industry. There they talk about survival rate, but then it's survival of the patient.
Yes, okay. Peri-implantitis, we have small numbers, quite similar. It's 5-9% between the 2 groups. And of course, we have peri-implant mucositis, but this one we see in the healthy patients. The problem is when we can place implants in such patients, of course, we cannot place immediately after transplant, because first 2 years, they are on really strong drugs for, how it's called, corticosteroids. So then we need to wait this period when they are in remission phase, and then we can place implants, and there are not any contraindication for such patients, because we see from the publications these numbers are really good, really nice.
Yeah. So you say there's no, I mean, a transplant recipient is not a contraindication. You just need to be very aware of the protocol. And that ties into a question that Dan Greco just submitted as well. Let me pull you back side by side for our producer. Dan is writing, so on patients with systemic diseases, do you have some different post-operative drug management? Is there any general rules or considerations that you can advise us?
Well, it depends which systemic disease is here.
Of course.
Or it's combination of systemic disease.
So let's start with some of the most common ones. Any things you can say there?
Yes. First of all, we have the most common is antibiotic prophylaxis, because we need to avoid any complications like endocarditis. Then we have to check of the anticoagulants, of course, and drugs for hypertension. because perhaps we need to increase the dose of the drug. Neurologists should increase the dose for the hypertension drugs. And of course, is the hygiene is very important, because we need to see this patient every second day for beginning. Every second day for beginning, and then normally we remove the stitches after 2 weeks, and then first week every second day, and then once in 3 days. So, and we, of course, we need to instruct the patient for the really rigorous oral hygiene procedures using chlorhexidine.
So that's a takeaway. So you say there's a very intense follow-up, and there's always the alignment. It makes sense, but it's good to reiterate. There's always the alignment with the other medical professionals involved to align the medication protocol with each other.
Correct.
Yeah. Wow. Now, to all our viewers who are still with us, who are just joined late, if you have any remaining questions on the topic of systemic diseases, or more broadly on the impact of systemic diseases on implant dentistry, now is the time to submit your questions. We've been talking to Victor Palarie for almost an hour already. Victor, if you would have to summarize, what are the key takeaways that people should keep in mind if they walk away from this hour and walk back into their clinics tomorrow?
Well, one moment. Well, I like to show you this picture. So this is a typical picture of a patient of a chronic disease or systemic disease. It was done by a soldier, American soldier after Iraqi war. So he got, because of the stress, can induce severe chronic diseases, and this one we can see on his face. And of course, normally we see these patients with chronic diseases when they enter to our office, looking just at the face, because they have a specific picture of the face. To summarize and a little bit to say, I say, okay, first of all, it's very careful to examine this patient. We need to know indeed what he has, what drugs does he take, because sometimes they forget about that. We need to talk with his medical doctor. And talking not meaning just take a phone, but it will be better to meet personally and to talk about this patient. I talk about really severe cases like anticoagulants and autoimmune disease. And to make, because the general practitioner, they know very good about this patient, about his chronic disease, but they don't know nothing about dentistry or about oral implantology. And of course, at the beginning, they'll say, no, we don't do anything. It's contraindicated. And then you need to explain what to do. And then you should come to the consensus with this patient. Because, for example, if you have a patient like a non-Hodgkin lymphoma or lupus, the general practitioner say never go to dentist, because then you'll die. You'll have an infection, and this infection will come to everywhere, and you'll have a complication, and you'll die. So this is, but we treat such patients, and that's why it's very important to talk directly of general practitioner regarding every single page.
Exactly. And I think that is the key takeaways that I've been taking from this session, Victor. First of all, we started with the oral cavity as the mirror of the body. We might be the first to discover something broader going on. So we should really look well after our patients. And then when we find something, or our patients acknowledges of a disease, the most important thing to go into an interdisciplinary team and really team up with the other doctors around this patient, right?
Correct, you are right.
Super. Thank you very much. Thank you so far for sending all the questions. I would love to ask our audience to share in the chat what they learned from this session and what their most important takeaways is. And make sure you like and share this video. We were now live, we're about to stop. And from then on, this video is available as a recording on the EEO channel for you to share with as many colleagues and friends across the globe as you can. And if you haven't done so, make sure you subscribe to the EEO channel. Hit the subscribe button right now, so you'll be the first to know when a new EEO Just Ask or a new video here on the EEO channel about implant dentistry comes out. And obviously, we want you to keep learning and keep interacting with us. If this is your first time discovering an EEO Just Ask, browse around, because we've done about 8 or 9 already about a very diverse range of topics, from sinus lift to ceramic implants, soft tissue management, bone augmentation, the one on COVID-19 in our practices you already referred to, Victor. So a very broad range of topics of Just Asked. And make sure you join us for the next one, which will be on July 6th. We'll be talking to Jose Manuel Navarro about digital dentistry. So mark your calendar as well. And well, Victor, this is obviously the end of your EO Just Ask. I hope you had a good evening with us tonight. How was it for you?
Thank you very much. It was amazing. Thank you very much for the nice introduction, Gerrit. And I'm hope to see the next year Just Ask question of Jose Manuel.
Definitely, we'll do that.
Thank you very much.
Thank you, Victor. Thank you, viewers, and have a good and safe night or afternoon or morning, wherever you are in the world.